Good morning, everybody.
Morning.
I was going to say all these bright and shiny faces. I'll retract the bright and shiny part. Faces. Some of them are bright and shiny. Some of them are less so. Yeah, I realize it's 8 o'clock in the morning, but it's not that bad. There's sun shining out there. This does not happen all the time here in Pittsburgh, especially as we get closer to winter. All right, take advantage of it. We have to drop the blinds. That's a nice thing. All right. So today I will finish the immune system, which I began Thursday last week. Obviously, we did not have class this past Tuesday because it was Democracy Day. And then, of course, after let's see, it's 8 o'clock, basically. Within the next hour, I will finish the immune system, and then I'll give you a little quiz, okay, that will cover the circulatory system and the skeletal system. Now, we also have, if I'm not mistaken, next Tuesday, an exam 2, all right? I will warn you now, I was extremely lenient in grading exam 1. If you put something down for an answer, I generally gave you, and it was wrong, I only took a point off, where arguably I should have taken more off. I will be more realistic in my grading, okay? So I just remember that the first exam was just to break you in, to get you used to it. Now, it's not like I'm necessarily going to take, say, 5 points out of 5 points if you get it wrong. Just give me your best shot. And just to remind you, if you don't write anything, I can't give you partial credit. If you don't put anything in there, it's automatically, that's it. You don't get anything, all right? So at least try. Okay, with those introductions, let's now progress with and continue with the immune system. This is where I left off. Remember, it's really hard to differentiate the circulatory system and the immune system. They're so closely associated in many ways, and the anatomy of the immune system illustrates that point. I'm not going to go back over this. You have that in the recorded lecture part. So let's continue with this because I have a lot to get to in this next hour. All right, now, with the introduction to the systems aside, the next thing I want to talk to you about is that you basically have 2 immune systems operating in your body. You have what is referred to as the innate system, which is a very primitive system. It's designed for rapid response. However, there is always a price to pay. So in order to have a fast response, you have a non-specific response. All right. Now, the second one is an adaptive immune response, which has specificity, but to sacrifice for specificity, it takes time to develop that response. So there's a delay in response. Both of these immune systems operate in you right now. And the adaptive, which comes later, builds off of this innate system. So what I want to talk to you about right now is differentiate between the 2 systems. And we will, and to do that, first off, we'll start with the innate, and we'll talk about what it consists of. What are elements that we associate with the innate immune system? As a first response, this means it has to be fairly rapid. All of you have either cut your finger, been bit by a bug, stung by a bee, whatever, and you have had an inflammation response. All right? So that is early response. Now, it doesn't matter. I mean, inflammation can't differentiate with what is injuring your tissue. It doesn't matter whether you cut your finger cutting up breakfast or stabbed your finger on an old rusty nail or had an incision performed under complete sterile environments in an OR. Your body, the innate system can't differentiate. It's not designed to respond to tissue injury, and that response will be the same. All right. Now, the inflammation being the first one. The next one, there are some additional types of things that are happening that evolved with us. Number one is interferon. These are proteins which are designed to take out viruses. right? So they don't differentiate between whether it's a good virus, a bad virus, a pathogenic. It doesn't do that. It's just designed to take out viruses. Next, we have killer cells. Killer cells basically exist. They're not specific, but they are designed to take out cells in your body that have been infected, either with viruses or bacteria or whatever. They can have some way of honing in on that, but again, we don't have specificity. Now, the last thing I'll touch base on is the complement system. Now, the complement system plays a critical role because it is the bridge between innate and adaptive immune systems. Now, this represents a variety of proteins referred to as complement proteins, and they are designed to, when they're activated, they do a number of things. We'll get into the details in a little bit, but they are designed to destroy foreign invading cells or damaged cells and so on. But we'll get into that in a minute. Just right now, just focus on complement system. All right, so those are elements of the innate immunity. Adaptive immunity consists basically of a couple of things. All right, so that consists of B cells and T cells. All right. So B cells and T cells are exposed to antigens that are associated, let's say, with some microorganism, foreign invaders, bacterial, viruses, whatever. They respond in regards to the B cells. They make antibodies, which are proteins which are designed to attack those elements. We'll talk how that works later. There are also T cells, which are killer cells, and they are also designed to take out that invader. Now, what the difference is B cells make antibodies, which are proteins. We'll talk how they work in a moment. And then the killer cells are actually cells doing the killing. So it is this interplay between both the B cells and T cells which provide you with this adaptive immunity, right? So those are the two types. Now, for the next few slides, let me focus on the innate immune system because, number one, it's more direct. And anyway, let's focus on it. So inflammation results, again, it isn't specific. There is some injury, trauma. It doesn't matter. There is a disruption in blood vessels. There are damaged or dead cells. It doesn't differentiate. You get this inflammation response. All right. So basically, what is going to happen is there's this whole series of events which are initiated upon tissue damage, which result in inflammation. All right. Now, what's the goal of this inflammation response? We have a damaged tissue, right? Let's say that damaged tissue, you step on an old rusty nail barefoot, okay? There's some inoculation with some bacteria along with that. So you have some injury, you have some potentially pathogenic bacteria. The role of inflammation as a first responder is to clean up that mess, all right? So think about you have this blackboard and it's filled with text. Before I can write on this with new text, I have to clean the old text off. So the same thing here. If I have this damaged tissue by trauma or whatever, we have to resolve that damaged tissue. So number one, we have disrupted blood vessels. We have dead cells. We have potential bacteria infection. The role of inflammation is to try to get this out of the way, to remove this. All right. There's some other elements involved, but that's the goal of inflammation. So that means that, generally speaking, you have to resolve this injured site or potentially infected site before you can heal it. All right. So inflammation has to precede healing. Typically speaking, if we go back to my history in orthopedics and maxillofacial, what do you use to resolve inflammation? Because you usually have this edema associated with inflammation. You have pain associated with inflammation. So what do? You take NSAIDs or steroids to suppress that inflammation response. That reduces the edema, that reduces the pain. That's the reason why you take it, because it reduces the pain. Now, always remember, this is physiology. There ain't no such thing as a free dinner. What's the price? Well, it's fine for an initial impact, but what if you keep applying those non-steroidal anti-inflammatories or steroid anti-inflammatories? You're going to continue to suppress this inflammation response. What that means is you're going to delay subsequent healing because you cannot have healing until you resolve the tissue damage. So what I'm trying to say here is that inflammation is critically important. Right? So it is important. All right. Now, what are the sequence of events that are associated with it? I'm going to I have a couple of slides here. We'll do it in general. So we have some damage. But the thing about it is there's almost an immediate response because there are immune cells, for instance, macrophages that actually reside in most tissues. Remember when we talked about the brain, we talked about glial cells, microglial cells. Those are immune cells like monocytes which reside in the brain. That means if I have a damage in the brain, they're already there. Same thing with other tissues in the body. They have resident macrophages. Now, because there is a delay in getting them from the circulation, whether they're neutrophils or monocytes, it takes time, right? So we engage these on-site macrophages. And what also happens is that there's going to be some damage. So there's going to be the release of different agents that are going to induce vasodilation. There will also be increased permeability. We'll talk a little bit about that in the next slide. The whole point is this leads to a localized edema, which we've already touched base on. All right. Now, what also can happen is that due to this tissue factor, if you remember when we talked about fibrin formation in the tissues, due to tissue factor, this acts to kind of wall off this site of damage. So that means that it minimizes it spreading out from that source, right? So this is all happening, and now we're bringing in leukocytes from the circulation. These are neutrophils and monocytes being attracted to the wound site. They're going to proliferate. They're going to do their job, destroy, consuming any invading cell, potential microorganisms, cleaning up dead and endangered tissue, whatever. And basically, they're going to be cleaning up that site. Once that's done, and only once that's done, we can have healing beginning, right? So this is more of a graphic format. So we have basically tissue injury, and then for all this is inflammation. So you're going to have during that injured cells you have a hypoxic gradient because you've disrupted blood vessel and oxygen delivery. We have the release of various components, everything from histamines to complement proteins and so on, prostaglandins. And what they're going to do is they're going to provide signals for vasodilation, increased permeability, and they also will be attracting those circulating leukocytes such as neutrophils and monocytes, right? So what we end up getting with vasodilation is this localized edema, all right? So what happens with that localized edema? That means that a site will look red in comparison to the surrounding normal uninjured tissue. It also is going to have an elevated temperature because I'm delivering more blood there. The reason it's red is because as I'm delivering more blood, there's more red blood cells, so I see that red, all right? So the next thing is with the increased permeability, that means, we have our edema coming on to play, and that means pain, that means swelling. So imagine you're playing soccer and you get your knee slammed. All right, you have an inflammation response. It's going to swell up, it's going to look red, it's going to feel hot. And if you move your leg, it hurts. All right? The inflammation is playing a role there, but with the edema, it's saying, don't move your leg, stupid. All right, so basically, when we think about an inflammation response, we think about heat, we think about redness, we think about swelling or edema, right? So everyone has experienced this. I'm sure every one of you has been bitten, say, by a mosquito. You see that little red welt that swells up. It's warm, it's red looking, okay? That is a classic inflammation response. Now, Once this tissue injury site is cleaned up, then and only then can we have healing. All right. Now, what are the chemical elements? The chemical elements can be oxygen gradients, they can be pH gradients, they can be gradients of like histamines and tissue fat, all kinds of things. But basically, for instance, if we have a nail here and we have some associated inoculation with microorganisms, and we're going to have the inflammation response, which is releasing all of these signaling molecules, they will diffuse to the circulation. And there they will provide a gradient which is going to attract neutrophils, it's going to attract monocytes. So normally, if there's no injury and no signals, those cells are just flowing through the blood vessels. But when they encounter these signaling modalities, they will stop rolling, which is called marginization. They're binding to the surface of those endothelial cells. They squeeze between those endothelial cells as diapedesis, and they migrate to that injury site, and they do their job. All right? Here, this is just to remind you, we covered this in the circulatory system, but I want you to remember that we have two mechanisms for inducing fibrin formation. We have the intrinsic, which means platelets are binding to injured vascular to the underlying ECMs underneath the endothelial cells. They degranulate and they initiate this cascade. The other is your tissue factor, which is released during tissue injury, and that then can induce fibrin formation in that local area, which helps to wall that area off. Okay? So all of this, which we've been talking about for the last 3 slides or so, is focused on the innate immune system. Now, the last thing I want to talk to you about is the complement system. Remember, the complement system is first and foremost, it is the segue between transitioning between the innate and the adaptive immune system. Now, it is a series of proteins. They're called complement proteins. You do not have to know all of these protein numbers. Okay? What I want you to know are 2 things. I want you to know how you initiate the complement system, and number 2, what is the result of its initiation? Okay, so let's take the first one, which is how do you engage or initiate the complement system? There's 2 ways. There is the classical way, and then there is the alternative pathway. The classical way actually involves the adaptive immune system because it requires antibodies, which are a product of the adaptive immune system. They bind to ligands, which can be associated with invading cells or whatever, and they will then initiate this complement system. The second is the alternative pathway, and that is that there can be specific proteins that, say, are associated with the walls of bacteria or even the capsids of viruses, whatever, and they can initiate activation of the complement system. Either one of these can activate the complement system. Once activated, there are 3 distinct pathways that can result. The first one is what we have already talked about, inflammation. The second one is that it will come over here and induce opsonization. What is that? So basically, think about these complement proteins being attached to the surface of, say, bacteria. That then means that that signals other immune cells to come and attack that and to, for instance, take it in and destroy it. So that's opsonization. So there's opsonization, there's inflammation, and the final one is the activation of the membrane attack complex, or MAC. All right? This one's kind of fun. So basically what happens when this is engaged, these complement proteins are actually inserted in the cell wall of bacteria, creating holes, and that kills the cell. All right? So that's pretty simple. I do not expect you don't have to know C5b, C9, etc. All of this. Again, all I want you to be aware of are the 2 distinct pathways, the classic pathway, the alternative pathway of activation, And then what's the result of that activation? Opsonization, inflammation, MAC, right? Now, this is where I'm going to stop. I've got time constraints and all of that. This is all I'm going to talk about with the innate. That it is not that it isn't important. It's absolutely critical, and we could spend weeks talking about it. But again, this is it. So let's talk about adaptive immunity. Okay. This is the one that has specificity. It also has memory. But let's first divide it into two aspects. We have two forms of adaptive immunity. One is active immunity, and the second form is passive immunity. Let's begin with passive immunity. In the case of passive immunity, your body does not establish immunity directly. In other words, you borrow immunity from something else. We are mammals. That means that you exist in your mom in utero for about 9 months. You are a foreign organism in terms of the maternal immune system because you only share 50% of the DNA. So that means that there is, and we'll get into more details when we get into the reproductive system, but basically, one of the last things to develop as a developing fetus is the actual immune system in that fetus, because it would have a negative, it would recognize mom as a foreign body as well. So not only do you not want the maternal side to attack the fetus, you don't want the other way around. All right. So, and number one, you don't need, as a developing fetus, until you're born, you are completely dependent upon mom, not only for nutrients, but for immunoprotection. Anything that she has developed antibodies to will be translated to you. All right. Now, when you're born, there is a delay before two things happen. Number one, the last two things to mature post-birth will be your immune system becomes activated. And number two, your gastrointestinal tract matures. Now, the reason your gastrointestinal tract is not mature is because the first milk that you consume being born is referred to as the colostrum. It is unique to any other time during lactation period, because during those first few days, it has extremely high levels of antibodies coming from mom. So whatever mom has antibodies to is being transferred to you. You've left mom, so there's no placental transfer. So the only way that you can acquire these antibodies is by ingesting colostrum. So this also means that your gastrointestinal tract is not fully developed, because once it is, you don't distinguish antibodies from any other source of protein. So it's just treated like a dietary protein. So during this, or these early first week of life, birth, after birth, you're getting antibodies from that colostrum. And at the same time, there are different hormones that are also in that milk, which are maturing your gastrointestinal tract. Now, after a week, doesn't matter, but your immune system has kicked in. All right. So this is referred to as passive immunity because your body did not make those antibodies. You borrowed them, right? Now, the second form of passive immunity is anti-sera. Okay, now there's a couple of types of anti-sera. For instance, why do you need anti-sera? You need instant immunity. Where would you need instant immunity? Primarily to correct for venom. So if you get bit by a venomous spider, a venomous snake, etc., you don't have, the innate immune system takes a week to generate immunity. Right? Depending on what bit you or stung you, you may only have minutes to hours. There's not enough time. So this is where anti-sera comes into play. So basically what you do is you can immunize various things to create antibodies to, say, these venoms, and then you can deliver those to you and you get instant immune protection. All right. Now, So let's say that you're in Australia, you get bit by a redback spider. You have about 2.5 hours to get some to treat it, or you're dead. You're in the middle of central of the continent. You're hours away from anywhere. But even though it's a small community, they have stocks of anti-sera to the various venomous organisms in that area. They can then start you on anti-serum to that redback spider venom, and you will survive. Now, that is again another form of passive immunity because your body didn't make them. Now, the advantage of passive immunity is the moment it gets into your circulation, you're immune. The downside is their time is clicking because those antibodies are only in there. They're only good for about 6 weeks or so, and then they're removed from the circulation. So there is a limit to how long you can do it. And number three, there is no memory because your body didn't make them. So sometime, let's say you get by that redback spider today, you come back, you're still in Australia, you get bit, say 6 months later, you still have to take anti-sera because the antibodies are gone. And you have no immunity because you used them, gotten those passively. So those are forms of passive immunity. Active immunity means your body's B cells and T cells are activated by these antigens. They will then undergo a series of processing and where they mature, and they will make antibodies and killer cells, which have specificity toward whatever that antigens they bit that activated them. And number two, they also have memory. So once you have been exposed and have developed active immunity, it can be good for years under some circumstances of your whole lifespan, which means that even though the first response you're making antibodies, and then of course after 6 months they go down, 6 weeks they go down, but maybe a year from now you get exposed again, your immune system remembers and starts making more antibodies of the same. All right, we'll get into the details how that works in a moment, but those are the two forms of adaptive immunity: active immunity and passive immunity. Now, in terms of the products of the B cells, they're antibodies. These are proteins. This is a schematic of that. It's a classic Y shape. You have 2 long chains, 2 short chains. And what you have here at the bottom, this here is referred to as the stem region. And up here, this is the Y region. The Y region is actually what's responsible for recognizing the antigens which have activated it. So they target those bacteria, cell wall proteins like lipopolysaccharide, whatever. The hinge region carries information for what to do when the antibody binds to whatever its target is. So maybe it's activating the complement system. Maybe it is activated, it's resulting in opsonization and promoting macrophage engulfment and destruction of whatever it's bound to. All of these are possible, okay? Now, I'm not going to spend a lot of time going over this, but what I want to talk to you about is this. In your body, when you're exposed to an antigen and it's activating let's just focus on B cells. It's activating these B cells. Depending what's going to result is a B cell will become an activated, which will become into a plasma cell, which then secretes antibodies. Depending on where that B cell binds to that antigen determines the site at which that antibody will bind to. So remember, your antigen has 3 dimensions, all right? And basically, when it is exposed to these B cells, they then convert to plasma cells. They're making antibodies, but depending on where they bind to what part of that 3-dimensional molecule they bind to means that their binding affinity can be different. So in other words, antibody B recognizes this aspect of the antigen, C this one, A this one. This results in antibodies that have multiple binding qualities to the same antigen. We call this polyclonal. all antibodies produced in your body are polyclonal based. It's random, and what that means typically when you're developing antibodies to an antigen, they will recognize different parts of it. All right. So if you remember, there used to be an old story about the 5 blind fakers, and they're touching an elephant. And depending on what part of the elephant they talk, they would describe it. So you have one touching the tail, it's like a snake. You have one touching a leg, it's like a tree trunk. You have another one's touching the trunk. That would be something else. All right. And the ears or something. So the same thing here. So the elephant is 3-dimensional shape. It had different aspects of it. So same thing where different antibodies will design to bind to different parts. The whole point of this is to maximize the ability to take it out. That's the whole point, right? So how many of you have heard of monoclonal antibodies, right? Monoclonal antibodies are a lab creation. They do not exist in nature. What you do is I'm not going to go into how you make them, but basically you isolate and you make a immortal plasma cell that will make an antibody that will only bind here. That means so you make them by making them random, but then you select those cells that make antibodies to target what you want them to target. This has great value for therapeutic and diagnostic aspects, okay? But just remember, monoclonals are engineered, polyclonals are natural, right? All right, now we have our antibodies that are designed to bind antigen. What happens now? How does that work? How do they enable the immune system? All right. So we have our antibodies, they bind to the antigens. There's a number of things that can happen. So they're not only binding to cells, but they're also binding to proteins. Think about that antivenom. That antivenom is a protein. And we want to block that protein from binding to receptors, which can result in your death. So we need to take it out. So when those antibodies bind to it, it can result, for instance, in neutralization, agglutination, and precipitation. The whole net effect is, for instance, it can bind to cells and clump them, and that makes it easier for the immune system to take it out, as well as precipitation means that it keeps them from getting to their binding sites, and then also by clumping everything together, it's more likely to be taken out by the immune system. Lastly, over here, it can also initiate activation of the complement system. Remember, that's the classic activation cascade. Now, because all of these are bound, that's going to enhance phagocytosis, which I just talked about. It's going to promote inflammation and cell lysis via MAC, and the activation of the complement system. So this is how your antibodies work, all right? Now, what's the lifespan of B cells and T cells? All right, so let's talk about that. And we're just going to be brief about it. But basically, remember, all immune cells have their cell source from hemostatic stem cells within bone marrow. So both B cells and T cells begin life as differentiated hemopoietic stem cells. All right, now they go into the circulation. Depending on if they're B cells or T cells, they have a different strategy. In the case of B cells, they will go into the blood and return back to the bone marrow, where they will become mature. All right, but they are naive, which means they haven't been exposed to an antigen yet. Right. In the case of T cells go to your thymus here, where they mature. And then they are, they're naive. They haven't been exposed. All right. Now, once we have them, they're now both the B cells and the T cells mature. They go back into the bloodstream, and they target those, for instance, lymphatic tissues. They go to the spleen. They go to the lymph nodes, etc., where they will then monitor for the possibility of being activated. Right. Now, basically, that's it. So if you have worked with animals that are called athematic mice or rats, that means they don't have an operating thymus, which means what? That means that they can't have mature T cells. And this is a classic animal model, which is used for transplantation and other things. All right. So I can put in human tissues into those mice and they will not reject them because they do not have operating T cells. Right? So I do expect you to understand the different, what is the pathway for B cells and T cells? Where do they come from? How are they activated? And then what happens to them once they're activated? Now, once they're activated, then B cells make antibodies and T cells become specificity. So let's talk about that. So again, I'm going to keep it simple. So we have an antigen. It's associated with the bacteria, whatever. It's going to initiate the innate immune system. All right. They also, and so these are non-specific, but then this is going to lead to specific responses. In the case of the antigens for B cell activation, it's going to go over here. It's going to activate the B cells. They will then become plasma cells. Plasma cells then secrete antibodies. We will also get a subpopulation of memory cells, memory B cells. Okay. Now, these effector plasma cells make antibodies, but they only live for a few weeks. Then they die. The memory cells can last your whole lifespan, right? So this is kind of what's happening here. We go over here, we're going to activate the T cells. It's a little bit more involved because the innate immune system is going to result in the activation of innate macrophages. Remember, they're part of the innate system. And they're actually going to facilitate activation of T cells. They're going to go here to mature immature helper T cells to mature helper T cells and their corresponding memory cells, which are critical for the complete activation of T cells. T cells will also you'll have them being activated, immature cytotoxic cells to mature cytotoxic cells and their associated memory cells. All right. So also, activation of B cells can help in the activation of the T cells. The net effect is the activation of both T and B cells. All right. So we have antibodies and we have these killer cells, and they have specificity because they're recognizing those specific targets. All right. Now, the key to remember is that whether I have these mature killer cells or these plasma cells, they have a limited lifespan and they're gone. The role of the memory cells is to remember. So if then somewhere down the road, months, years down the road, they're exposed to the same antigens, they will begin the process again. But it's quicker and faster. So let's think about what is that response. I told you that adaptive response takes time. All right, let's focus really just on antibodies because that's the easiest thing to do. And so basically, let's say here's time 0. You're exposed to a flu. I don't care, whatever. So basically, there's a delay. And in about a week, you're going to have activation of your B cells. You're going to get plasma cells producing antibodies, which are specific for that antigen. And you're going to see an antibody titer. That's the antibodies that are specific for those antigens circulating in your blood. All right. Those will peak and they go down after about a month. You will usually have some residual antibodies, but they've gone back almost to baseline. All right. What happens so at this point, you re-expose the immune system to that antigen again? What that means, so what's happening here is the plasma cells are dying. The memory cells are still there. I get exposed, the memory cells will then replicate themselves, making more plasma cells, make more memory cells, and we will get a faster and larger titer for those antibodies. Okay? So if you remember COVID, remember they gave booster shots. That's the point of booster shots. The first time you gave the shot, you got a moderate response, but then after a couple of months or so, they would give you a second one, and you get a much heightened response. In some cases, you keep giving responses, you getting increased titers. Yes?
How does the body decide which antigens to make memory cells?
So when we activate, say, a B cells, when we activate those B cells then differentiate at the same time to either plasma cells, which are making antibodies, or memory cells, which then are designed to make more of those specific plasma cells. So those are co-activated at the same time.
So does that happen for every single antigen then?
Yes. Where we have activation of B cells, yes. As well as T cells. You will always have memory cells because that's where the memory part comes into play. Okay. All right. So remember, though, this is specific for that specific antigen. If I get exposed to a new antigen, I start the whole process over again. So I'm old enough where I couldn't buy, there were, fancy that you couldn't just buy growth factors. You couldn't buy a lot of antibodies. You had to make them if you wanted them, or purify them if you wanted them. And there were, in my graduate career, one of the things I had to do was make antibodies. And I would make them in sheep, okay? So, because I needed a lot of them. So, and sheep are easy to bleed. So basically what you would do, you would inject in the lymph nodes here, like here under the arm, under the legs. And then then I would bleed after about a month, and I'd get a little antibodies, which was titer. All right, and that's fine. But then it goes down. And then about 2 or 3 months later, I give a booster shot, and the antibody titer goes up. I don't want to harvest the blood yet because I don't have enough yield. Usually what I would do is I have to give 3 separate boluses. All right. Now, and that would keep that antibody production up for weeks, which means I could bleed those animals. I want to keep them around I kept those animals around for a couple of years. So I only would bleed them periodically. But by the time I got done doing these booster shots, I could get a high yield over a long time span. And then once the yield starts to go down, I give them another booster, it goes back up again, and I can keep harvesting, right? And this is basically the same way your COVID and flu vaccinations work, right? So here's basically what I want. This is just another way of presenting it. I want you to remember how it works. So again, your B cells are exposed to an antigen. You're going to have the formation of 2 types of cells, plasma cells and memory cells. Now, and then you're going to get antibodies from the plasma cells, but they have a limited lifespan. They die. The memory cells continue. Now you get exposed to another antigen. They're then going to make many more plasma cells and many more memory cells. And this gives you the higher antibody titer that I was talking about in the prior slide. And then the more it's exposed, the more it happens. When you think about it, it makes sense. The design for this, engineered into your body, evolutionarily speaking, is to provide you with the most protection. So when you get exposed to an antigen, whatever that may be, first, you're going to get B cells and T cells activations and memory cells but you're not necessarily going to get a lot of stuff, okay? But then the insurance policy are those memory cells, because if you got exposed to it once, there is a likelihood or possibility of getting exposed to it again. Then you get exposed to it again, you have a heightened response and a heightened protection each time you're exposed to it, all right? Okay. That's all I want to do, at least for this class, talking about immune system. Again, I want to reiterate that it is one of the most complex systems in the body, and we could really get into we could get into regulatory T cells and it's just very cumbersome, and we're discovering more about this system all the time. But this is all I want to do for you to focus. So for the next 15 minutes, I want to talk about, since this is biomedical engineering, most of you, I want to talk about biocompatibility, okay? So biocompatibility is something that so what is a biomaterial? Anything that goes in or contacts the body, right? Even a protein drug is a biomaterial. A lot of engineers don't think about it that way, but it is, Okay. Usually you're thinking of a device, you're thinking about some sort of a construct or cell therapy or something. All of those are biomaterials, right? Now, what I want to do is put the biomaterials and biocompatibility with the immune part that we just talked about. And again, this is just going to be high level. Don't worry, not too much in depth. I used to teach a course, a lab course called a host interactions lab, where you would be introduced to inflammation, you'd culture cells, and you would test for biocompatibility and all that kind of stuff. But it was an 8 o'clock class. It's a 3-hour lab. You had 2 of those a month. It wasn't popular. Okay. Those who took it did, but most people hated that time frame. But nonetheless, plus you also had to do all your own cell culturing and so forth. The TAs didn't do any of that. You did all of that yourself. But anyway, let's focus on biocompatibility. So biocompatibility, what does that mean? That means that there are different types of responses that can be expected to a biomaterial. You can have a mechanical, so maybe it's creating some wound as it's being put in. Maybe it's disrupting normal functionality of your leg. There can be a chemical reaction due to the chemical nature of that material. There can be pharmacological effects. There can be surface compatibility issues as well. All of these, and then there's more, all of these can be associated with biocompatibility. Now, if we have a completely biocompatible material, that means that it just occupies space. It isn't specifically interacting with the immune cells or anything like that. There will be a response. All right. So if I'm going to surgically create a sprocket, I'm going to put this completely biocompatible material in there. What will happen is you will get a fibrotic formation around that material, whatever it is, because your immune cells, i.e. your neutrophils and macrophages, their goal is to remove any foreign materials. It's not recognized as an enemy or an infective agent or anything like that, but it tries to destroy it. So normally, the way that works is a macrophage engulfs something and then destroys it. But this is too big. It can't get around it. So first thing it does, it fuses to make bigger and bigger macrophages, but it still can't engulf whatever it was. So it will then form a fibrous capsule to isolate it from the rest of the body. All right. One of the things too is, but to be completely biocompatible, it should not irritate the surrounding structures. It should not create an undo. I said undo. Why do I mean by an undo? Because in order to put that material into the body, I'm going to have to move some stuff around. I'm going to have to create a wound site in order to insert it. There will be an inflammation response no matter what. But that's what I mean by undo. Okay. So we don't want allergic reactions. And lastly, the one thing the FDA is always concerned about biomaterials, which I've worked in that area for a long time, they're always concerned about cancer. All right. But typically speaking, that's not particularly something we really worry about, but we have to prove that it doesn't make cancer. Right. Now, biomaterials, basically, we can fall under a number of categories. They can be inert. That means they're designed to be put there and not have direct interactions to excite the host tissues. They can also be interactive. That means we do want them to interact with the host tissues. They can be viable, which means they perform some function or another. And then there's also ones that maybe they're only designed to be there for a short while, or maybe they have to be replaced, like catheters have to be replaced on a regular basis. They're not permanent, and some are permanent. Okay. Now, if we have our tissue interactions from the host tissues, we can have a minimal response. So we have usually what that means, we have a minimal, if we have a material in there that has some volume, we're going to get capsule formation, but it's minimal. All right. Then we can have a chemical induced response. And that's because maybe in orthopedics, we're using some metal and it's releasing some aspects that are toxic, and they can have either an acute or a chronic effect. And And then we can have physically induced response. Let's say I'm putting a piece of plastic in, it's in the joint, there it forms wear debris over years of use, and those microparticles actually can excite the immune system. Okay. And we can also have basically a necrotic response. Again, orthopedics. There is something called bone glue, which is basically a heat activated polymerization. It's a polymer. You add A and B, and then it gels and forms. But one of the byproducts is heat. So one of the things it does is during the process of it maturing, it kills all the local cells surrounding that. So that's a necrotic effect because it outright kills the cells, right? Okay, now there's a lot of issues and a lot of things that are controlling how the body responds to, say, implants. Number one is where am I putting it? Am I putting it in the appropriate site for what I want it to do? And then, of course, if I put an implant subcutaneously, whether I put one intravascularly in the muscle, in the bone, it depends. We have to make that biomaterial to fit that particular environment. Species, that just means what is it made? Is it plastic? Is it ceramic? Is it metal? Whatever. Is it natural? Then, of course, what's also important is the degree of associated injury where I'm deploying it, because that more injury means more immune response, more inflammation. Okay. And then all of these can impact the healing around it. Now, an implant response. Think about it, think about, for instance, you get a thorn in your finger. That's technically a biomaterial once it's in your finger. Now it's in your finger. What do? It breaks off below the skin and you can't grab it with your fingertips. You can't grab it with a pair of forceps. Do you take a needle or a pen, sterilize it, and go digging for gold? No, you leave it alone. Inflammation will impart over the next couple of days. There's going to be edema, swelling, and what happens is after about 3 days, it will just be extruded naturally. Okay? So that is extrusion. Now that's one way. Another one is, well, I put that material in and I designed it to be bioresorbable. So it resorbs over some time frame. Or maybe it is to be integrated and encapsulated. It's big enough, say it's a pacemaker, which is put under here in my deltoid muscle. And then it is a biocompatible material, and there is a big fibrotic capsule formed around, but that doesn't impair its function. All right. So, and that's what that capsule formation is. I surgically put pumps and rats. I put all kinds of devices within these ARPA-H protocols I'm on. I'm putting these kinds of things in animals, both mice and rats, all the time. I can guarantee you, when I just took out a pump out of a rat, it was in there for a month, and it had a capsule surrounding that pump, which was about about a good millimeter in diameter all the way around. All right. It doesn't take long to form that. It was a completely biocompatible device, but it was so big that there was a capsule formation. Right. That's just that's a natural part of it. Now, there is some cases, especially in orthopedics, where we want host tissue ingrowth, because we need that for mechanical stabilization purposes. Because in orthopedics, one of the things, like I'm doing an artificial joint, so I need to replace my femur joint, the upper head of my femur. I cut it off here. I need to replace with an artificial joint. But in order to have mechanical integrity, I need the stresses that are encountered on that artificial implant to be translated to the lower femur and to my feet. All right. So there needs to be mechanically stable. All right. So I will focus on this. This is my last slide. Yes.
Due to the size, if it came down to, I guess, trying to move up an animal size, would that be something that would hold back, especially since humans are larger? So in terms of size, as you progress, it may not be an issue in a larger animal.
No, it will always, because you're going to also increase the size of the device to be appropriate to the size that you're putting it in. So it doesn't go away. It's relevant all the way up. Okay. So I'm showing you an experiment here where femur implants, these are implants that are going in the femur, and how you put it in is you remember the femur is a long bone. It's kind of hollow in the middle. So what you're doing here, you're going to put an implant. It has a stem, which then is designed to fit inside this marrow space of the femur. Now, this is designed for biological stabilization. That what you want is you put it in, you want the host bone tissue to grow in to create a mechanically stable device. All right. So the key to that is two things, aside from the biocompatibility. Number one is you need to have initial mechanical stability, because bone will not migrate, will not form in a moving environment. It needs a mechanically stable environment. So that implant, once I put it in place, it needs to be mechanically stable. How is that achieved? So you want to press fit. So what you do is you want to ream out that marrow space so the implant stem can fit in. You want enough pressure so that when you stick it in, it doesn't move. You don't want it to be too loose. You don't want it to be too firm because you can split the bone. So there's some play there, and there you have to adjust, but you want to press fit. If you have a press fit, you have a mechanically stable environment. The bone and the surrounding bone will grow in, and most of these implants have a porous surface so to facilitate tissue ingrowth. And once you have that, you have a mechanically stable implant. All right. So what happens if I overream and I don't have mechanically stable? And that's what this slide shows. So here we have a mechanically stable implant. This is a cross-sectional area. So this is the cross-section of the implant. Here is the surrounding bone in blue. Note that the bone comes up and then interdigitates in all the pores in this structure. All right. This creates a very mechanically stable implant. All right. If I overream it, and basically in this one, it's stable. So here's my bone, here's the implant, and it's stable. It doesn't move. What if I overream it? It's doing this. So now I'm getting all this micro movement in the bone. This does not translate to bone repair. Okay? What happens is you get the deposition of soft tissue, and that's the pink part here. Note that you don't have direct contact of bone with the implant. It's all pink soft tissue, which means that in real time, so in this case, I can't pull the implant out because it's integrated. The bone is integrated with the surface of the implant. This one comes right out. It's not mechanically stable. That implant will fail. All right. So this is just kind of illustrating that. This is done with dogs, by the way. All right. So I'm going to stop there. I have 2 minutes, and I'll use that to pass around the quiz. But anyway, that concludes the immune system. Now, put everything away. That means all textbooks, phones, computers, everything. And I will pass the quizzes out. One page, but you know, one page I think it's fine. Yeah, it's on time. Any actions over here? Does everyone have one over here now? Okay, flip it over, put your name on it. Again,